Hello and welcome to the first of two Monivent webinars on the use of respiratory function monitoring. Our first speaker is Dr. Michael Wagner of the University of Vienna. His presentation entitled Respiratory Monitoring in the NICU and During Training. Dr. Wagner, the floor is yours.
Thank you for the invitation to this symposium. I will talk about our experience with respiratory monitoring in the NICU and during simulation-based training. My name is Michael Wagner and I am a neonatologist at the Medical University of Vienna, and I am also responsible for the local simulation training center. First, I would like to acknowledge support by the Sol Foundation for one of our studies called VAQ-CPR, where we assessed visual attention when using feedback devices. Further, Monivent provided us with a training device as well as technical support during the study, but nobody besides the study team had any influence in the study proceedings. Also, I have no financial conflict of interest to disclose. First, I would like to start with some background. Ventilation is a key aspect and a vital skill for resuscitation, as well as for planned intubation of neonates, infants, and children. Since ventilating a child can pose difficulties, especially for novices, simulation-based trainings have been implemented to teach the skill to young doctors, nurses, and students. Currently, most often an instructor-led training approach with feedback based on clinical science, such as chest rise or heart rate increase, are used. However, several studies suggest that the use of a respiratory function monitor provides objective and accurate data which could possibly augment ventilation quality, evaluation, and feedback based on just clinical science. It has been shown that by using an RFM, the trainee's performance can be increased significantly. If providers rely on clinical parameters, it has been shown that even experienced providers have mask leaks and ventilate children outside the recommended tidal volume target range. With a ventilation above the target range, there is a risk of lung damage for the infant, and the tidal volume below the target range has a risk of hypoxia. The use of a respiratory function monitor can help to achieve better quality. A respiratory function monitor is a novel tool that can improve positive pressure ventilation by providing real-time information about ventilation quality. Here you can see an example of the CE-certified Monivent Respiratory Function Monitor NEO 100, which has a flow sensor connected to the ventilation equipment with a wireless transmission of ventilation parameters to the monitor, giving real-time feedback on ventilation quality. Parameters shown on the monitor are weight-specific tidal volume, peak inspiratory pressure, mask leak, positive and expiratory pressure, and respiratory rate. The use of an RFM improved the quality of PPV in a simulated environment, but little is known about how providers use the RFM best in clinical situations. Therefore, we designed a randomized controlled study, also first in a simulation-based setting, later in a clinical setting, with the aim to compare different teaching methods utilizing a RFM. The primary outcome was the proportion of ventilations within the recommended target range for the tidal volume, compared between three different groups. We investigated whether one of the evaluated specific teaching methods is most beneficial for the trainee's performance. The study design was as following. 170 students from the Medical University of Vienna were included in this study. Participants had to perform a simulated elective intubation, including manual ventilation before, during, and after intubation. Beforehand, participants received instructions on the RFM and ventilation techniques with an instructional video. The participants were divided into three groups, each following a different teaching setting. Group A was the control group, following the current standard protocol with a supervisor giving feedback and the RFM not visible, neither for the supervisor nor the participant. In Group B, the RFM was visible for the supervisor but not the participant. Group C allowed both the trainee and the supervisor access to the data from the RFM. Here's an example of Group A, where you can see a traditional teaching and feedback setting. The supervisor was only able to see clinical signs such as chest rise or the patient's heart rate variations. The RFM recorded ventilation quality but was not visible to anyone. On the right side, you can see examples of monitor recordings when mask leak or tidal volume was too high or tidal volume was too low. In the second group, the supervisor was able to see the RFM and therefore could give objective feedback to the trainee. The idea was that with such a setting, the trainee can still totally focus on the patient without any distraction by an additional monitor, but still the monitor helps the supervisor to give more objective feedback. In the third group, both the trainee and the supervisor were able to see the RFM. Here in the video, you can see real-time feedback of the monitor. Based on our preliminary results, the most effective teaching method in regards to optimal tidal volume seems to be Group C, meaning that participants are more likely to perform high-quality ventilations if they and their supervisor have visual access to the RFM. We think that similar effects can be expected when using these teaching methods within a clinical setting. We also identified that the biggest problem for inexperienced trainees seems to be the mask leak, which can be improved by using a feedback device. Preliminary data from 100 participants was collected so far. The average proportion of ventilations within the target range across all groups was 48%, with 31 in Group A and 51 and 63 in Groups B and C respectively. Median mask leak ranged from over 60% in Group A, the control group, to about 41 to 45 in the two other groups. Average ventilation rate did not differ much between groups and was approximately 26 to 27 ventilations per minute. As regards to the proportion of ventilations within the target range, statistically significant differences were seen between all groups. Therefore, using an RFM helped to improve ventilation quality if only seen by the supervisor compared to no RFM, but also the group where both the supervisor and the participant were able to see the monitor had significantly better results than in the group where only the supervisor had visual access to the monitor. Regarding the mask leak, we could detect differences between the control group A and the two other groups, but no significant difference between the two interventional groups B and C. As you just heard, our study was not only about the impact of our RFM on ventilation quality, but also about the optimal setting for using an RFM. The idea is that while there is some evidence that feedback monitors help to improve quality of care, it is unclear if they could also be a possible distraction. Here's a study by Herrick and colleagues where they used eye tracking glasses to analyze the visual attention on a respiratory function monitor called the Newlove box when being either visible or masked, and they found that median fixation on the RFM was significantly higher when it was visible. In another study by Katz and colleagues, the researchers were interested in what part of the RFM participants focus most often. This topic is also important for monitor design, as some monitors show graphs while others just show numbers, and it is unclear what design helps best to improve quality of ventilation rather than distract from ventilating the baby. Here in this study, they found that the tidal volume waveforms were most frequently focused at, as you can see in the heat map. However, different monitors have not been evaluated in such a manner. Based on the previous study, where we have identified that using feedback devices helped to improve the quality of care, we were further interested how visual attention affects the quality of care. Therefore, we designed this randomized crossover simulation study. As in previous studies, we found that performance quality improved with real-time feedback for both chest compressions and ventilations. We further observed that more experienced participants spent more time looking at the feedback device than on the mannequin. These participants may have needed more time to interpret the feedback from the device or relied on their haptic memory, requiring less confirmation of their task by looking directly at the mannequin. However, also the non-feedback group's dwell time, so the focus on specific areas of interest, was mostly on the infant's chest and mask, likely to determine optimal chest rise. Probably, the participants were looking for feedback or needed feedback on how they were doing by paying attention to the areas that would tell them the quality of ventilation. It is also reasonable that repetitive and regular training with feedback devices might decrease subjective workload, while still impacting the quality of resuscitation and ventilation positively. This manuscript is currently in the submission process and final results will be available soon. Last but not least, we now also try to transfer the use of RFM into clinical settings, as you can see here in the video. While we know that using additional monitors potentially help to increase the quality of care, you can see that we nowadays also have a problem of space within the clinical environment. Therefore, the optimal positioning is still an important research gap. Therefore, there are some emerging key questions for future research, such as the optimal teaching setting when using feedback devices, whereas we were already able to show promising results for groups where supervisors and trainees can both see the RFM, possibly because of an improved communication between the two providers. We also speculate that visual and auditory feedback helps to better understand the situation and leads to quicker reactions. Further, the optimal use in a clinical setting needs to be determined, as well as the best instructional design for monitors, and last but not least, the impact on patient safety and outcome. To summarize, there's evidence existing that RFM improves the ventilation quality, but still the optimal integration in a clinical and teaching environment needs to be evaluated. More and new technology will be available in the future to also overcome problems such as a lack of space in the clinical setting and optimal visualizations. Thank you for your attention, and if you have any further questions, you can see my email address here, and I'm happy if you write. Thank you.
Apologies to people who are our audience who are watching the presentation. There seems to have been some technical issues there. We'll try and correct those as quickly as possible. In the meantime, I'd like to ask Dr. Wagner. Firstly, I'd like to congratulate him on an excellent presentation, and also congratulate him on the award he received from the GNPI for his reInvent study that looked at the use of respiratory function monitoring in the training situation. There is an opportunity to ask Dr. Wagner some questions if you would like. Please enter them into the chat box. If we are not able to answer all the questions during the webinar, we will forward them to Dr. Wagner and send his comments, answers back to you. Dr. Wagner, I would like to start by asking you about the frequency of training. There is some evidence there about the benefits of low dose, high frequency training. What are your thoughts on that, and how often would you recommend training to take place for neonatal resuscitation?
Thank you very much for the opportunity to talk here and also for your question. So I think it depends a little bit about what kind of training we're talking about. So if it's just neonatal life support basic skills, then usually we know from literature that you need a training at least every 3 months, but optimally even more often to get a good quality of the training benefit for the babies. But if we're talking about specifically using feedback devices such as the Monivent Neo 100 or training device, we've seen in our study that especially people who are experienced with taking care of babies, it's a little bit different setting for them when they use feedback devices. So their quality still improves, but as we've seen is that they need more time to focus on the feedback device and to get to know what or how it can help. So I guess we need more training so that the people know how to use it, so that the benefit and the quality even improves much more. So I would suggest to have a training, and this could be quite a short training, 10 minutes, 15 minutes, at least once a month.
Okay, thank you for that answer. We have received a question here. The evidence, there is evidence for using respiratory function monitoring on improving performance. Does this help, or is there plans to integrate this into NLS courses and also local skills training? I think the question there
That's a good question. That's a really good question. We know from literature that those devices are very helpful, but still it's not routine during official NLS courses. What we do, at least in our center, as we did some studies and as we've seen that the quality really improves, at least in the training setting, is that we use it routinely for every training, so that people really see how the ventilation quality is, and so that they can adapt according to it. But it's not routine in the official NLS courses at the moment, but that's something that we are working on, and we hope that it will be in the future, because we really see the benefit, and more studies will come in the next few years, and so hopefully the next update will have it implemented.
Okay. Thank you for that. There is a question here about leakage. Your reInvent study showed that there was significant reduction in leakage when using a respiratory function monitor. The effects of that, are those skills retained? Has there been investigation into retention of skills?
We have not studied it within this study, so and there's no study out there that really looked into that specifically. But we know from another study where we used a chest compression feedback device. There we did a short time retention. So we had an assessment after the intervention, and what we've seen is that in the groups that used the feedback monitor, they also had significantly better results afterwards in the assessment, even without using the feedback device.
Okay.
So there is some skill retention when you use a feedback device in the training setting.
Okay. Dr. Wagner, I think we have time for just one more question. The question coming here is, do you think we have something to learn from flight pilot simulation regarding cognitive ergonomics in the design of monitors? I think the question is.
Yeah, I think one of the problems, and I think I mentioned it in my presentation too, is that more and more monitors are coming up, and I really like how technology is helping us in improving how we take care of patients. But I think most of you know, or at least in our center, it's a problem of space. So the space in the NICU is very limited. We already have a lot of monitors, and we don't know where to put all the monitors at. So that's something we are trying to investigate at the moment, to really see how maybe, again, here new technology can help us to acquire or to get more space in the NICU. So for example, I had it in my talk yesterday. Maybe some of you have seen it, or you can watch it later on. It was in the patient safety new teaching and new media session. So as it's recorded, you can watch it later on. What we are trying to do at the moment is also to use technology such as augmented reality, where you have glasses on the head to see different kind of monitors, so that we gain space, because we don't need to put the monitors next to the patient. They can be anywhere in the room, but still connected to the patient, and you see the monitors as holograms in front of you and in front of the patient. And I think that's also something that pilots are using. It's also something that the car industry is using. So they also have this augmented reality head-up displays. And I think that's something that will come into medicine, but as always, it takes a little bit longer because of regulatory issues.
Dr. Wagner, I'm afraid that's all we have time for now. Thank you again for the presentation, and congratulations again on your award for the reInvent study.
Yeah, thank you very much, too. It was a pleasure to talk and discuss here.
Thank you again. Thank you and goodbye.
Thank you. Bye.